significant issues on the 2016 update factor, as well as an update on the market shift. I guess let's start out maybe by going around the room and find out also who's on the phone. David Romans from the HSCRC.
Shirley Tilko, HSCRC.
Donna Kinzer, HSCRC.
Jerry Smith, HSCRC.
Ellen Engler, HSCRC.
Medicaid Planning, sitting in for Tricia Reddy.
Mike Robbins with the Maryland Hospital Association.
Kristen Polio, Adventist Healthcare.
Paul Parker, Maryland Healthcare Commission.
Ann Meck, University of Maryland School of Nursing.
Jim McGee, Transit Employees Health and Welfare Fund.
John Hamper, Care First.
Bob Murray, Care First.
Stu Gutterman, Commonwealth Fund.
Steve Ports, HSCRC.
Is there anyone on the phone? Okay. All right, well, we're going to get started then with the discussion of the update factor. We sent out the draft report to you, or made it available, I think, on Friday, so hopefully you've had an opportunity to look at that. I have just a couple of slides that summarize sort of the key points as well. But, the first slide is just the recommended balanced update, which is also in the report, which I think you have available to you on page 5. For the most part, the numbers are what you've seen at the last meeting and very similar to the numbers we've been looking at for a few months now. The major change or new item is the infrastructure line, which was TBD previously. We're recommending a 0.59% infrastructure allowance. There's two components to that allowance. It's 0.4% for the GVR hospitals only. It's sort of an across-the-board funding amount to help with care coordination, chronic care management, and provider alignment. And so we want to make sure that we're successful in the waiver, not just in year 1, but throughout the 5-year period. And we believe that there's a need for additional investment to make that happen. And the second piece is a 0.25% that would be given out on a competitive basis rather than everyone receiving it. And the concept here is that there would be a competitive process where hospitals submit applications by December 1 of this year, and then awards are made at some point in January of 2016. So the other item that's worth mentioning on infrastructure is on top of the competitive process to facilitate a certain amount of accountability, we're asking that each hospital submit a report in December outlining its strategies both in the short term and the long term for implementing care coordination and provider alignment, kind of what they're going to use their infrastructure money for and what their sort of long-term strategy is. That would be reviewed by the staff, and if it was poorly done, it could result in funding being adjusted in the future.
David,
yes, sir.
Just a question. Is the 0.59 total, is that a one-time adjustment, or is that intended to be a permanent adjustment?
It's intended to be a permanent adjustment.
Okay. And you're making a distinction between the two components,
yes.
The 0.25, I mean, we're calling it infrastructure, but the 0.4, or the net 0.34, mm-hmm. We don't have any rules around that, right? I mean, there's no process. It sounds like a general adjustment, whereas the rest of it, I mean, hospitals could use it for anything in the way this is laid out, not infrastructure.
It is a general adjustment that we are, as I was saying, requiring a report in December from each hospital with what their strategies are, both in the short. Yeah, everybody has to submit a report just to explain what their short and long-term strategies are. And then if they want to compete for the competitive money, they'll have a specific application.
If it doesn't meet your rules or standards, then it could be removed.
We're certainly going to review it. We expect everyone to submit, and if there was some inadequacy, we would go back to the hospitals and try to get them to make some adjustments.
Well, can you clarify that a little bit? I know that the initial reports for fiscal 14 and 15 for infrastructure are due in September. but it was my understanding when those reports were, when the instructions were sent out, that the issue wasn't to account for every single dollar. It was to list out all of the different programs, identified to the extent there have been outcomes that can be identified, what the results of those programs were. But there wasn't going to be a dollar-for-dollar accounting, and certainly no indication that if I hadn't spent all of the initial infrastructure funds by the end of fiscal 15, that somehow some amount of revenue would be reduced in future rates.
Right. What we're asking for in this December report is more of, I would call it more a strategic plan, or here's what our vision is, and here's what we're trying to accomplish. And all we're saying is if someone submits a really poor, not well thought out vision, we're going to go back to them and have some dialogue about, this doesn't look like it's going to get you or the state where we want to get.
Okay. Well,
So this isn't going retroactive on last year's infrastructure adjustment, but we really do expect people to spend the 0.4, really spend it on infrastructure for the new model. And, we expect to get a plan in December on how it's going to be spent, and then we expect it to be spent on the plan.
Okay. Thank you. Well, I appreciate that clarification. Can I clarify the 0.25? The way I read the narrative, it sounded as if the 0.25 would be provided basically on an annual, that is, at an annual amount. That is, the annual impact in fiscal 16, as you've indicated here, would be 25 basis points. So in terms of fiscal 16, does that mean you would be putting essentially 50 basis points into rates over the second half of the year, or just 25 basis points in terms of the math of this model?
So the amount that would be given out would be equivalent to 25 basis points for the full year.
For the full year. So if they got all of that revenue on January 1st, to generate that by the end of fiscal 16, they'd essentially have to increase their rates by double that amount.
Right.
But then you would make an adjustment to price level that
into fiscal 17.
For 17.
Yeah, that's
Mechanically, what we're doing for ease of administration is we just restate the global budget for the year. That way we don't actually have to do price leveling. We just raise the global budget for the whole year by 25 basis points, and then that avoids technical issues.
So they would have to just adjust the charging.
Yeah, they would get into compliance. But we have to have good plans submitted that have good reasons to spend that money. So that's really to say, people have to be ready to deploy that money in a way that would be helping to drive the new model forward.
If I may, real quick, from the Medicaid standpoint, we agree with Care First on the need to, I know Donna's been working really hard in the HSCRC to make sure that the infrastructure developments are aligned with all the work that's been going on in care coordination. And we just wanted to highlight real quick something we learned about recently, a presentation from New York on their DSRIP, which is a delivery system reform incentive payment program. And it's a section 1115 waiver, but in this case it could align well with the kind of two-part planning versus incentive payment structure. What New York is doing, they are forming regional or hospital and non-hospital-based collaborative partnerships. They're given upfront monies similar to what HSCRC is proposing here to complete a community needs assessment and develop project plans based on that. And they receive a pot of monies for that. Upon execution of the plans, which are very locally tailored, and upon achievement of milestones, they receive incentive payments after that across 3 areas, which are clinical improvement, system transformation, as well as population and preventive care. It's a 5-year program. They're just ramping up, and the incentive payments for the first year are weighted more heavily towards process. And as the project goes on over the years, the weighting goes further towards the more outcome-based milestones across the clinical improvement, population health, and system transformation and financial sustainability. So we just wanted to put that out there for everyone's consideration. as an interesting example or model to keep in mind as we move forward with that. So feel free to let us know if you have any questions.
Can I also just raise one other clarification on the competitive bidding process? And I think it's somewhat obvious from the way the 25 basis points have been built in here. But what I'd like to do is in the presentation to commissioners, I'd like to make sure we identify that the specialty hospitals and the TPR hospitals that are not eligible for the first infrastructure amount, the 40 basis points, would be eligible if they're either part of a coalition or independently submit this report and describe the care coordination strategy that they will employ, that they would also be eligible for that funding as well, because the previous infrastructure amounts have just gone into the global budget hospital. I believe that is the Commission's intent from the way I look at this, but I'd like to have that clarified.
Okay.
Thank you.
But just another clarification. The 0.25 with the submission is not automatic. There's an approval process. You know, there's oversight. There's reporting and all. Correct.
Somebody has to actually be ready to do something that is going to be selected out of a competitive process. So, you know, if they file a plan, they're not ready to execute, then they're not going to be selected to get money. We have to have folks who are ready to actually execute.
Right. We would not expect every hospital to receive a competitive grant.
They might get one in the next year if they're not ready this year. Maybe there would be one in a year after.
Plan and get the money.
No, it's not an automatic get just because you submitted the plan. The plan is to go along with the 0.4 for the GBR hospital.
So now I'm confused a little bit. First off, the reporting requirement is for all hospitals, right? Did I understand that correctly? And then in addition to that, there's sort of a RFP process or a proposal process that it makes you eligible for the 0.25%. That's correct?
Correct.
The part that lost me is the grant process, that gets rolled into that hospital's rate, what I understand from what you just said. And it's not a lump sum grant kind of thing. Okay, thanks. No.
Question on the TPR. I understand this is a GBR just getting into the game, and they need infrastructure. I got that. And TPR did get monies 4 years ago, and probably have spent it, and they're finding out that they need more dollars for infrastructure as time goes forward. How long will there be a differentiation in this, and at what point will you have considered not to continue to raise the issue about the dollars given to the TPR 4 years ago? 4 years is a long time in this business.
Well, you're right. That was just said that it is permanent money, so the TPRs still have that money in their base. I would say there's also been pretty significant difference in the financial performance between the TPR and the non-TPR hospitals, which suggests, you know, if we want to see the GBR hospitals make the kind of investments we're looking for, that they are more in need of the funding at the current point in time.
No disagreement. I'm not disagreeing with that at all. I'm just thinking that there ought to be a time when the differentiation does not need to exist. I'm only raising that. You may want to give it some thought. I get it for this year.
We're expecting ROI, so we're expecting the hospitals to generate savings and then use that to be making the next round of investments. We don't know exactly what the right cutoff point is, but we think the TPR hospitals are getting ROI now, and they're reinvesting their ROI, which is what we would expect the GBR hospitals to do too, to help expand their programs once they get kick-started.
They're all making, everyone's going to need to make investments outside the hospital. Care management groups, physician practices, embedded case managers, behavioral health services available in a physician practice. Those are all significant investments. And as we so often look at performance of health systems and hospitals, you can see that while they may have profits on the HSCRC side of the business, they're making lots of investments in the non-regulated sides of the business in order to achieve the population health readmission targets. So it's a constant endeavor to find dollars for those. investments. And as I said, I'm not really looking for an answer today, but food for thought for the future. I understand the position today.
Could we also just back up a little bit? I know you've had a few meetings just to go over these preliminary draft recommendations outside of the work groups. But what was the rationale behind picking the number, the 0.59? You know, we're in a circumstance now where hospitals are making pretty substantial profits. They still have losses on physicians and presumably contracts that are still oriented toward volume, where they could roll those back and reduce those losses. You also have the dynamic, as you mentioned, Donna, where when you invest money in these types of infrastructure amounts and reduce unnecessary utilization, there is a return on investment. So I think from a public standpoint, there would be a question as to why this magnitude, particularly relative to last year when the magnitudes were substantially less. So I was wondering what was the process that you all went through to come up with the 0.59 as the appropriate number this year?
Part of it is we've been in the care coordination work group process, and we've had some consultants working with us and trying to look at what is it going to really cost on an ongoing basis to make care coordination work statewide. And that estimate was in excess of $200 million. So we're trying to work, add additional funding into the hospital rates to start, providing the resources necessary to do that on an ongoing basis. And this gets us fairly close to that figure. This on top of what's been done in the last couple of years. And so it builds us towards sort of having enough money in the hospital system to make the investments that are necessary.
So this is, and I wasn't part of the care coordination, but so $200 million on an ongoing basis was your estimate each and every year, because this is permanent money.
Yeah, I think it was in excess of 200. Other questions, comments at this point? So just to finish on that slide, you can see in the middle subtotal in the blue area, you have about 4.6% growth in revenues on a per capita basis of 4%. But then we need to take into account a couple of sort of offsets, the uncompensated care that we've discussed previously, and there's a recommendation before the commission that helps reduce the growth, as well as the MPEP assessment being zeroed out based on the actions of the legislature for this coming year. So that brings us down to a net revenue growth of 3.19% and a per capita revenue growth of just over 2.6%. So this is sort of our preliminary thoughts on what we'll be recommending to the commission at their next meeting. Again, if there's further input, we're interested in hearing it. Also want to just put the numbers, a little bit of context. At the last meeting, we went through sort of the two financial tests or parameters of the waiver to give you a sense of where we stood. So what we've done is we've filled in the fiscal 16 column of this chart with what we're recommending for fiscal 16, and we've revised our fiscal 15 estimate based on the latest information we have. So the blue row is that the maximum per capita revenue growth allowable under the waiver through fiscal 16 would be 9.21%. With our recommendations and our estimate for fiscal 15, the per capita growth would come in at a little over 5%. The other way of looking at that growth is if you sort of back out the uncompensated care and the MPEP, because they're not really harming the bottom line of hospitals. They're being taken out because of changes in what's going on. You end up with a higher growth rate of 7.8%. But again, even you doing that math, you end up below the 9.21% maximum growth. So the recommendation keeps us, within the parameter there. And then there's more detail on this on the Medicare analysis in the write-up. But we've assumed that we want to save 0.5% against the nation again in fiscal 16. And then we've taken that sort of Medicare growth rate and converted it to what would work for an all-payer basis, which would say that we could grow 3.45% on an all-payer basis and still achieve on the Medicare side, the 0.5% savings. And you can see this is about a 0.25% difference between what the staff are recommending and the maximum allowable growth. So the recommendation is within both parameters based on our analysis. And the final slide I had just summarized the recommendations. The kind of core base inflation amount shown at the top there, 2.4% from the global budget hospital revenues, 1.6% for revenues that are not within the global budget cap, and then 1.9% for the psychiatric hospitals in Mount Washington. We've talked quite a bit about the infrastructure, and then just to make sure we're all on the same page, the Medicaid deficit assessment, the legislature did not change the amount this year, so we're proposing the same amount and same allocation as was done last year. So that's pretty much our overview of the report and where we are. Any additional comments or thoughts?
I just have a question. Could you provide some detail or some information on how you came to your rationale for the 1.9% for the specialty hospitals?
Yeah, so the specialty hospitals, the 1.9% is we looked at the Medicare growth rate for psychiatric facilities, what they're proposing. They just came out with their proposed rule in the last week or so, and it was a reflection of this 2.7% growth, and then they have a productivity factor of -0.6 and a Affordable Care Act law change that requires a 0.2 adjustment. That's how we went. We went from their 2.7 sort of market basket growth to 1.9 by making those two adjustments, productivity and the ACA adjustment.
I want to come back to the infrastructure adjustment, if I may. The 0.25%, the sort of grant money, as we call it, is that part of this total bottom line, or is that an addition?
It's part of what's shown in the bottom line.
Part
included.
Of the 5.9%.
Yes.
So all hospitals, this is where I'm getting confused. All hospitals are paying into it, but only some hospitals get it, or no?
And the money will be, so if you get a competitive grant, if you're the hospital, you would get money added to your rates. You have the authority to charge higher rates. Your global budget would go up a little bit so you could generate the revenue to support
part of the total global budget.
Right. No.
For an individual.
No, this is an add-on to individual hospital rates based on the applications that they're submitting, and once those.
I understand, but how does that affect the total process? I mean, we come back to it.
At the end of the day, when you add up all rate increases, whether it's across the board, spread like butter, or individual, you'll get the amounts that you talked about.
Right.
Okay. Yeah, it's just the maximum.
What Jim's saying is, if some people didn't get it, but it's factored in here, this is the maximum.
Right.
Yeah, that's max.
Right. And that's similar to the 0.5% allowance for unforeseen adjustments that's in there as well. On day one, on July 1st, that money won't be in hospitals' rates. But over the course of the year, there may be allowances that the staff, the commission needs to make that would put into individual hospital rates or all hospitals' rates an amount not to exceed that 0.5%, because that's what's being approved in the revenue update process.
I have a two-part question. The first part is with both the 0.59 and then the 0.225. I'm assuming that as you go along, you'll be developing criteria for these plans that the hospitals will know about in advance and that they can, benchmark themselves against.
Absolutely.
And then you mentioned in terms of the evaluation for outcome, it's shared savings. Is there anything that's built in there about appropriateness of care? Because you'd hate to see savings achieved by keeping people out of a hospital or an emergency room that really needed to go back in a timely fashion. So is there something beyond just the monetary aspect of the appropriateness of care being looked at in terms of how these plans are evaluated in the end, or how the outcomes are evaluated in the end? I'd hate to see somebody circling around in an outpatient setting that could have been more appropriately and quickly treated back in a hospital, but is being kept out because it makes the savings number look better.
Mm-hmm. I mean, we have to develop a specific criteria for the competitive grants, and we can certainly try to make that clear. And we're certainly doing everything we can to monitor trends at the individual hospital level. And if we see unusual trends that isn't potentially for avoidable utilization going down, we're going to be investigating that.
Yeah, I just harken back to a case of in the era of managed care gone wrong, where a patient was treated who had appendicitis and should have had an appendectomy a whole lot sooner, but didn't, and was circled around in an outpatient setting until she finally suffered a ruptured appendix and then got to the hospital to have her appendix removed, as well as had to treat the peritonitis that came around.
There's always stories, but there's always stories on the other side too of people getting surgery when they didn't need it, and they died from the surgery that they didn't need to have, and that was in fee-for-service medicine. So we can come up with a lot of stories, but yeah, I mean, I think the whole program will be designed around finding high needs patients and then making sure they're getting better care. So that's really that's the whole plan that the care coordination work group is driving forward, is how to focus on high needs patients and patients with chronic conditions and making sure that they're getting better care. And that's the main strategy focus that is being developed, and how to get the nursing home interventions improved, so that we reduce infections and we reduce avoidable admissions, and so those are the main strategies that are being focused on that will be part of the planning process. And so we'll be looking for plans that focus on those main strategies as opposed to plans that focus on other strategies that might be less patient-friendly. And that's been the Commission's strategy from the beginning, is to focus on the care improvement strategies. So I also listened to 90s complaints, and I don't want a repeat of them. I don't want to run on people saying they couldn't get an MRI when they needed one.
I wanted to ask one other quick question. Do we know, the slide 4, you're looking at the difference between the all-payer maximum to achieve savings, which would be kind of predicated on the Medicare test as well. But on the all-payer test, do we have a sense of what's going on nationally? Previously, I think in 2013, things had slowed down quite a bit. The nation essentially was meeting an all-payer test nationally because their growth was less than gross domestic product. Do we know any additional information in terms of how things are going there? Because I think, it's certainly not a given that the waiver will be continued when we go back in to request continuation of it. Obviously, there's a phase 2, but there's also the demonstration that Maryland is really differentiating itself from the nation and also generating significant savings for Medicare. So just keeping that in mind, I'm just wondering where we expect the nation to be going and whether we are really differentiating ourselves.
We've looked at some data from some national sources that just on a price basis is very modest growth nationally, but in terms of revenues, I think largely because of the Affordable Care Act implementation, revenues are growing really healthily, and because they're getting uncompensated care is down for those hospitals. So there is quite a bit of revenue growth.
There's some evidence of volume growth in from the materials that we're looking at. There's evidence of volume growth in the rest of the country. I mean, according to the FTE analyses, the FTEs are up in the rest of the country, and they're fairly flat in Maryland. And according to the data, volumes are up in the rest of the country, and they're fairly flat in Maryland. So that's, we wish there were a relatively good source of increased information that was timely.
Yeah, I just, a timing question on the infrastructure is that this $200 million, that is all going to be through the competitive process, and is that starting January 1, 2016, or is that starting the beginning of the fiscal year? What kind of is the time frame on that?
So let me clarify a couple of things. So in each of the last 2 years, in fiscal 14 and fiscal 15, the Commission added a 0.35 infrastructure adjustment. So there's infrastructure that's already been built into hospital rates, and it's continuing. It's ongoing. It doesn't go away. So there's already a significant amount of money there. We're enhancing that in 2 ways. We're adding, for the global budget hospitals, we're adding 0.4%. July 1. So they're going to get that. They're going to be able to use that. But we're asking that by December they let us know what is their short and long-term strategy for all of the infrastructure money that they're using. And then we're, on top of that, we'll have this competitive process for another 0.25%. So at the end of the day, hospitals will have roughly 1.3% of hospital revenues will be sort of put in there for infrastructure activities. And the 0.25% is just, one portion of that.
Thank you. So not having the sense of the global revenue we're talking, that 1.4?
Like 1.3 or say roughly.
What is that in dollar amounts roughly?
It's a little under $200 million.
Okay. All right. That was the $200 million.
Yep.
Thank you very much.
Any other questions or comments before we move on to the next topic? Okay. I'm going to turn it over to Shula. Who's going to talk about shared savings.
Let's see if I can speak. So you have a copy of the draft recommendation on the shared readmission shared savings program for the rate year 2016. Basically, the shared savings program started with the admission readmission reduction program, which is the episode-based payment program we had before global budgets. And it was required by the federal law because the CMS required us to have same amount of savings from readmissions as they do in their readmission reduction program. With the new contract we signed last January, now the amounts of adjustments are totaled as aggregate amount at risk, so we no longer have the specific requirements for the readmission program. Nonetheless, we would like to continue the shared savings program as we have been in the past 3 years. The reductions are done using the readmission risk-adjusted rate, so it adjusts for case mix differences in the hospitals, and the reductions are based on the readmission rate. So the higher the readmission rate hospital has, the more reduction as a percent that they have. For this year, what we are recommending is to update the measurement. Last year, since we were in the transition period, we kept it as the measurement as the admission-readmission program, so ARR specifications. Our readmission reduction program, which is an improvement program we have, is based on CMS definition. So there are some differences, and I'm happy to explain the differences in more detail, but generally, we are recommending to move the measurement in line with the readmission reduction program. So that includes both the same hospital readmission as well as readmissions to other hospitals, and have the amount to be at 0.6% of total revenue. Last year, we had 0.4% of total revenue, so it's one-time adjustment. So the net impact of the reductions are 0.2. So in the back of the recommendation, we provided several tables based on preliminary data. Appendix 1 is the way we risk adjust the readmission rates. So in this case, columns A and B, A is the hospital's total admissions, B is their expected readmissions based on their case mix, C is what's observed. So we calculate the risk adjusted rate by the ratio of observed to their expected. And taking this readmission rate, so for Meritus, since they're at the top as an example, their observed rate is 12.23%, when you look at the readmission rate, they are 9% below the expected state average. So their readmission rate doesn't change as much as stays at 12.26. In Appendix B shows the way the reductions are calculated. So again, if we take the Emeritus, so their risk-adjusted rate is 12.26, and then we reduce that by the same amount. So here we calculated that as 7.8% reduction. So we multiply 7.8 times the 12.26. So that gives you the total inpatient revenue reduction for this hospital. And we then convert that to their total revenue reduction, which amounts to 0.55%. So lastly, in the Appendix 3, we provided the net impact of these reductions. So last year, Emeritus had 0.47% reduction in terms of their total revenue. So that goes in back, so as a positive, and now we are taking 0.55% out. So the net impact for the shared savings for Emeritus becomes 0.08% of their total revenue. I can go over again if I went too fast.
No, I just wanted, for the average reader of this, would it be safe to say that the larger that net impact in 2016, that there was some worsening of their readmission rate or their risk-adjusted readmission rate relative to their peers?
Mm-hmm.
Would that be a safe way of describing it?
There are two main reasons for that difference. One, as you mentioned, Mike, is their readmission improvement. They may have gotten worse. The other one, since we changed the measure now, before it was only same hospital. Okay. Now it's all hospitals. Got it. So if the hospital has higher readmission rate to other hospitals, that will also explain the net impact differences. So you could take Kernan. I noticed Kernan was one of the ones that significantly impacted. As you know, Kernan is mostly rehab hospital. Majority of their readmissions are happening to other hospitals. So you see that the Kernan is, let's find, it's down towards the bottom.
Right. Rehab and ortho.
Rehab and ortho, yes. That's their new name. Right. So you see that the impact for Kernan is quite significant, right, and it's mostly because of the change in the readmission rate. Okay. Sure.
I'm looking at an expected readmissions of 2,080 for the first hospital,
mm-hmm,
and an observed of 1,907.
Mm-hmm.
So that tells me that they performed better than expected.
Yes.
So why are they getting a revenue reduction?
So in this program, since we can't really judge what the readmission rates are, whether they are high or low because of the limited risk adjustment that we have, all hospitals are receiving reductions. But then the reductions are still calibrated to their readmission rate.
And Jim, there's a separate readmission reduction incentive program that if they were doing better than expected, they can get the potential for award under that program.
And the expected is based on Maryland, which is above the national average. So the expected would be too high unless you scaled it down. But so this is really expected based on the average.
They're not having as much success in reducing readmissions nationally either. Maryland started at a higher place, but I think
it's still a higher place.
It's still higher, but it's coming down quicker than relatively to the rest of the nation.
If you remember, you can go back and look at the final recommendations for the readmission reduction program, which was in March. We did some modeling comparing our Medicare readmission rate, our progress versus the national, and based on the data that we received that time, raised right, the reductions are slowing down both nationally and also Maryland, but we still have significant gap that we are not progressing fast enough to be able to reduce that by the end of the 5th year. And that's one of the reasons why we want to keep the shared savings, again, on the readmission number. You may recall or not, we had an intention to expand this measure, maybe include all the potential avoidable utilization as the source of the savings. However, given our progress on the readmissions, we think that we should keep the program on the readmission rate this year and reevaluate it for the next year.
I think one thing that would be helpful, because we've had actions taken by the Commission on both the fiscal year 2017 quality-based programs and the amounts at risk, as well as this particular program, which is for 2016. If in presenting this, that we remind the commissioners what total amounts of risk are for 2016, including this incremental increase of 0.2%, or the total amount of 0.6, but again, I understand that within that it's a 0.2 incremental increase, because again, I think the concerns that we expressed back in the March meeting was, as you compare that total amount of revenue at risk to the revenue that's being put into, or the revenue growth being put into this program, it's significant amount of revenue for, certainly for individual hospitals, that they could see a substantial portion of their revenue growth for the next year taken back by the sum of all of the different programs. So I just think it'd just be helpful to remind commissioners of what we have in place for 2016.
I'm sure you'll do that.
Well, I'm asking you to do that, if you would, please. Thank you.
So certainly by June we'll have the final quality assessments computed, so it will be in the final as both potential and realized calculations there. Any other questions? All right. So I'm going to turn to the market shift update. So as we are progressing on data analysis front, I thought it would be good to go back and refresh the whole methodology, since we've been looking at the pieces at each meeting. So from the last month's commission meeting, 2 overarching principles were discussed by the commissioners, one being that the market shift adjustment should not undermine the incentives to reduce avoidable utilization. We interpret, or we apply this principle as to separate shifts from the utilization increases or declines. And the second guiding principles that was discussed was the market shift adjustment should provide necessary resources for services shift to another hospital. That was also termed as being equitable. If the hospital is receiving additional patients from another hospital, they should have enough resources to take care of them. And then I termed that as money follows the patient. So in terms of the separating the utilization changes from the market shifts, the algorithm we developed is really looking at the shifts in the marketplace. I just simply, let's assume we have 2 hospitals and we are looking at 1 zip code. In year 1, you see that the volumes are equal in both hospitals with 50 discharges. In year 2, you see that the hospital A in the market share adjustment has 250 and the other one has 100. So both hospitals have volume increases. In this scenario, our algorithm is telling us there is no shift. This is a market share growth, and we are not recognizing any shift happening between the differential utilization increases in these 2 hospitals. For us to be able to really see the patients are moving from one place to another, we expect that one of the hospitals would have a decline and the other one is going to have an increase. So that's in the left side of the column where I show that the hospital B has decline of 25 discharges, and the other hospital still has a utilization increase. So this is one of the principles in the algorithm that when you're looking at it, there has to be a decline in some place in that geography. In order to calculate those shifts, we basically group the hospitals for the utilization declines or increases, and then we do the calculations accordingly. And every hospital either gains or loses based on their percentage of their increases in column D. So in this case, in this example, we have 654 ECMAT growth. So don't worry about the ECMAT. I'm going to get to it in a minute. So 654 discharges increase for the gaining hospitals. And then you see that the declines are totaling to 129. We compare the increases to declines. So in this case, we award 129 market shift, positive market shift to the hospitals with the utilization increases. And since it's larger than the increase, the declining hospitals are losing all of their volume. If you look at column D, the Holy Cross Hospital gets 76% of 129, which equals to 99 discharges as a market shift. So their increase is 500, but they are only getting 99 because that's how much we determined that shift to be. Any questions on this? Yes, Jim.
My question is there any context to this in terms of any population-based benchmark or anything, whether or not?
You mean we haven't incorporated the utilization, population increases and the aging into these calculations because it gets too complicated once you start to estimate how much increase the zip code should have.
I was thinking more just in terms of the appropriateness of what's being done.
It is very difficult to judge without the context of what the shifts are. What we try to do is by limiting it to zip codes and service lines, we are still focusing on the shifts between the hospitals. Whether it's appropriate or not, we are tracking their avoidable utilization and also the other markers for the shift. So that's the only way we can do it.
And one of the issues that we've had is that, and we understand completely what you're doing and all, but we're not driving down deep to find out what's causing the shift. So in other words, here we're just assuming that Holy Cross Suburban, Montgomery, and Hopkins are all getting, you know, some of the volume that's being shifted from these other hospitals, whereas it could be one or two of these hospitals could be inefficient, and therefore, you know, their PAUs could be going up or something else. And offset, maybe Holy Cross is doing a great job, and that maybe all 129 shifted to Holy Cross. But we're not. What's the reason I'm not really drawing down that?
It's because it would take us about 2 years to complete the exercise. So we're going from, you know, I think what we're going from allowing a pass-through of all volume to only allowing a volume shift. So it's a change. And John, if Care First can tell us how they do it, we'll, I'm just kidding.
No, but I mean, I can see some hospitals being very concerned about the dynamic of, you know, here I am, you know, making all these changes to drive my volumes down, but I'm not getting the full benefit of it because my, you know, other hospital in my market may not be doing this.
So I think that's why we wanted to do it at the zip code as small as possible, because then you avoid some of those differences. If Holy Cross, well, Holy Cross is an increasing hospital. You know, one of the declining hospitals, Upper Chesapeake here, is implementing a value, you know, a avoidable utilization program. They are driving their volumes down. If they have to do it on a community basis. So given a zip code, you would think that all the volume should go down because of a successful program in one hospital. So in this case, yes, we are making an assumption that the, you know, everyone is getting in proportion. So the shift may be happening from one single hospital from this list to another hospital. But nonetheless, if hospital is successful reducing it, most of the volume should go down in the zip code.
Is the goal in the future, though, to try to understand where you are and the limitations and all in doing this? And clearly, it's sheltering or protecting the system against moving additional. It's everything's like murder neutral. So I mean that's a huge improvement. But is the goal eventually to really be able to try to identify those really efficient hospitals and give them more of the reward?
I think our goal is to try to adopt alignment strategies with the other providers and focus and help to drive focus across the entire total cost of care toward the three-part aim. And so that's really, I mean, generally that's the strategy that we're trying to execute.
Julie, on building on your example of the community that everybody kind of collaborates to keep patients out of the hospital, so everybody has a decline in admissions, so there would be no reallocation then.
Correct.
And it also, isn't it true, it just goes back to the question John was raising, that in calculating that market shift, we've carved out what we've defined as potentially avoidable utilization. So if you actually increased your potentially avoidable utilization, you wouldn't get rewarded for that in this calculation. Now, we can argue potentially over the definition. Is that too large or too small a definition? But at this point, for what you have defined as potentially avoidable utilization, that's carved out of hospitals that both gain market as well as those that lose market. Correct calculation. Thank you.
So, as you know, the market shift is a complicated question, but I just wanted to remind you it's one piece of the puzzle. So in the global budgets, we have other volume adjustments. So we have demographic adjustment to provide additional revenue for volume increases because of population growth and aging. We have the Medicaid expansion utilization increases this year that will be implemented. So in this case, if you remember the Holy Cross 500 increases, some of it could be the Medicaid expansion that you see, and that is taken care of in the Medicaid expansion bucket. The market shift here is really focusing on the shift between Maryland hospitals. So if the patients are coming or going to out-of-state providers, then we have to find another sources to measure that and adequately compensate hospitals for the shifts. Ray, do you look like you have a question?
Sure.
Yeah, go ahead.
I was being patient.
That's all right.
It's not typical. I understand.
I couldn't.
It's not a perfect policy, and we've had lots of discussions. I think we had one Friday. Friday, was it, Donna? We had a conversation. And you wanted to go to the zip code, then the problem with zip codes could be small cell variation, which means there's not many admissions or discharges out of a particular zip code when you get out into some counties outside of the suburban areas. So I understand your intent. Would suggest that you consider some sort of a threshold. That was talked about early on. It was not adopted, but within one of your other policies, transfer policies, for example, you have thresholds and limits built in there. We've had lots of discussions. You've excluded the other impacts that you were talking about. You're going to pull transfers out. Should you pull the demographic adjustment? Maybe you're doing that in this rendition, and it's been gone by me. But pull out the other pieces and consider a threshold. I mean, because recognize it is not a perfect policy, and maybe we shouldn't get down to the last dollar the first time out of the box.
Yeah, I did look at the cell size thresholds, and given the small cell sizes we have, it didn't work out. But once we have the general calculations, we could take a look at it again. So, yeah. The issue is with the transfers, we had a very set goal, and we were trying to get at the maximum changes. since market shift is applying all the hospitals, it's hard to create a threshold where, and then try to keep the policy revenue neutral. But something that we still need to consider.
It's a balance. We have 50% adjustment. So in some sense, those who are losing volume are keeping 50 cents on the dollar. So that's a threshold of sorts. We're not thinking about putting a threshold on the market shift adjustment right now. That's not in the staff's consideration right now.
Well, some of it comes down to
we're not thinking about doing that.
Some of it comes down to how do you define? Are you effectively defining PAUs when you pull them out? And that's not a discussion we can necessarily have in a meeting like this. But as I have to agree with some of what John said. And that is that basically everybody's got to be pulling at the same level in order for this to work, and for some hospital who may be doing the right thing not to be penalized by a market shift. I think early on with some of the TPR hospitals, we saw that as they did the right things, their market share declined because they eliminated cases, and then they continued to refer some of the tertiary cases down the road. So it looked as if an apparent decline in market share. You pull out all the PAUs effectively, you should address that, and I'm not sure that the definition is adequate, I guess, Don, is what I'm trying to suggest as well. That's why I understand you're not going to consider thresholds. Okay, you've made that point clear. So let's look at how we define PAUs. Maybe we can take that offline.
No, I think it's something that we can work on an ongoing basis. I mean, I'd like to put sepsis in the PAUs. I think that's a PAU, but I think next year we can continue to try to build out additional definitions of PAU.
Julie, I have a question. I'm just curious to continue the Holy Cross example, where they will be getting 20% through the market shift of the volume that they've seen. And now, again, because PAUs are already out of this, one would assume that this is good volume that they're getting.
No, I'm sorry. There is no good or bad volume, as Mike says. In this case, there is a volume increase. And
let's just leave it at that.
Right.
I'm just saying that it's not volume that we wouldn't want to recognize.
I would no.
Okay, let me get my point out. All right, because and maybe this is the crux of the question that I have, is how we view volume changes. And so in this case, there's 500 increase. There's 99 or 20% that's being recognized. Now, that leaves 80% that's not being recognized, which I think was a little bit back to your point. And I'm just wondering, has it been tested, like just even using one single hospital, to see if when you look at the demographics and the Medicaid expansion, the sum of the adds up to what is appropriately necessary to keep that hospital viable? Because I'm concerned with all these changes that there's more, when you're reducing volumes, the system seems to work, but when the volumes are increasing and you're only getting some sense, a moderate cents on the dollars for those increases, 2 years from now, maybe you can absorb it for a year, maybe two, depending on your starting point. But have you looked at this in the context of a hospital that's actually got this kind of change?
If you don't reduce your avoidable utilization, you're going to run into problems with this model as the population ages. And that's what the waiver is about, is moving away from a volume-based model. And folks are going to have to attack the PAUs to make the model balance.
And I understand that. I think we are. I guess one of the concerns that I have is how quickly the
you're going to be living off of lower inflation then, because the inflation factor is it's full inflation here. There's money in the inflation factor you weren't getting before because you were getting volume. So there's 0.8 there effectively to cover your volume increase if you want to spend it on volume increase instead of something else, that's fine. We're okay with that.
All right. I just wondered if
it's going to be that. I mean, that's the risk model. That's the risk model that is under the new waiver. Is you have to reduce avoidable utilization and invest in programs to improve quality, and that's how the model is going to balance. It's not going to balance on the old volume model where we add up all the volumes and give you the money. It won't work.
Yeah, I understand what the goals of the program is. I guess I do have a concern with the demographics and the aging population, that the ability to balance what is happening out there, because we do have folks that have already had lifestyles that have created the rising risk, that we're adequately recognizing that. So my question was really, if you're only going to get out of some of this volume a percentage, are we making it up on the other components like you're saying? And again, looking at this, having already said it carved out PAUs. So my point, I will voice my concern about this.
Well, it's the way the whole country's moving. So, in terms of trying to move away from a volume-based model that pays just for volume growth.
Yeah, I think the field clearly recognized when we went into this model a year and a half ago or more, that significant amount of risk that we were undertaking. And I think our debate in this forum and before the Commission has been then within the constraints of the all-payer cap, just how much revenue funding is needed or growth in that revenue funding from year to year to recognize that risk that has been taken on for that the investments that we need to make in order to make sure the infrastructure is in place to get the avoidable utilization out as quickly as needed to still live within the constraints given this other volume growth that may be reasonably occurring, whether it's the Medicaid pent-up demand or other things. So I just don't want us to understate the amount of risk that was taken on, because we're essentially, what you're saying is 100% at risk for any of that utilization growth. There's some amounts that are being provided through the model, but there may be a significant other utilization changes that may be appropriate, may not be appropriate. That's part of what we'll have to continue to evaluate. But it is a huge amount of risk, and I just don't think we should ever understate that we took on with this model.
This is Mary Jo. I have a...
the hospital should be...
This is Mary Jo. I'm sorry I was late. I have a quick question. Since the model is done at the zip code and service line level, you wouldn't expect huge service line shifts year to year, but there's possibility that technology changes and changes in standards of care could shift the service line revenue. Are you looking at the kind of statewide service line volume changes to monitor kind of the exogenous factor of technology change or shifts between modalities?
No, the only thing that we are trying to do is for some services on the outpatient that used to be an inpatient, we are trying to find a way to combine it. We did it for the observation cases. If they stay 24 hours or more, they are treated as part of the inpatient service lines. And for the next year, our intention is to do a similar combinations for cardiac surgery and some of other surgeries that could happen inpatient or outpatient, spinal fusion, things like that.
Right, and there's always things coming off the inpatient-only list for Medicare. But you might, it's not an immediate issue, but over time, if you don't want to lock the formula into the service line distribution that existed in year one. So again, you're getting I have no problem with the formula, and first few years you wouldn't expect that service, broader trends in the treatment of medicine cause service line changes, but you would expect that over 3 or 4 or 5 years. And so you may want to begin to look at kind of the broader trends, and so that we can revisit, what the baseline distribution should be, since the formula is dependent on shifts both at service line and zip code.
Yeah, maybe let me finish my presentation because some of those things are addressed already. In terms of the baseline, it's updated every year. So unless we have a dramatic change in technology that would shift the service lines, gradually I think the formula would pick up any changes happening in the marketplace.
Okay, you rebase each year.
Yes.
Essentially. Okay.
Jim, you had a question?
It wasn't so much a question as a comment. I just wanted to say that in light of the enormous risk that hospitals have undertaken, I think the hospitals need to be congratulated for performing so well in the first year, and not only hitting all the benchmarks, beating all the benchmarks, but making money in the process. So doing a good job.
Well, we appreciate that, and we also do recognize that this is a collaborative process, a collaborative effort, that it's not just what we're doing individually in our hospitals, but we do need the resources that are being provided through this update process and the discussion we've already had, and these other policy adjustments that we're making. I think it's been a collaborative process throughout, and I want to make sure we recognize that as well.
And I think, going back to the inflation adjustments, we did step forward and not make a negative productivity adjustment last year, and because of the hospital's success, we're able to do the same thing again this year because the hospitals were able to hold the line on volumes and revenues overall, and so we're able to do the same thing again this year with the adjustment, and that's the same process we're taking forward again.
So we talked about the exclusions. So readmissions, we have a 30-day readmission excluded from the calculations, as well as the prevention quality indicators. These are the ambulatory sensitive admissions. We do agree that the definitions might be limited, that probably for next year we would want to look at things like sepsis and other things to include in the potentially avoidable utilization definitions. The other protection we have for hospitals who are doing a good job in reducing their utilization is to limit their losses to the gains on the other side. So in this case, if the losses are 100 admissions and gains are 200, the gains are limited to 100 only. So we are not making the hospitals with declining volumes to pay for 200 admissions in this scenario. On the opposite end, if the losses are 200 and the gains are 100, the shift is only for the 100 admissions. So the rest 100 is staying with the hospitals with declining utilization. Again, it's trying to make sure that if hospitals are reducing their utilization, it's staying there with them unless there's an increase in another place.
Sheila, I just wanted to indicate that we've tried to do some modeling of this to take a look on an average basis what the variable cost factor would be for hospitals that are experiencing decline. We'll be presenting a paper with that analysis, but just very sort of an advanced discussion of some of our findings with regard to hospitals that have realized declines over a 6-month period in fiscal 15. We found that the variable cost factor associated with that was about 34% on average. It varied dramatically from one case to another, so it wasn't predictable going in. But what that means is that for a hospital that reduced utilization, say, by $1 million, you might be able to take out some small sliver of that, saying it's potentially avoidable utilization. But if the hospital has 50% fixed costs, then they would realize $500 million of that in savings under the GBR. But by then having an effective variable cost factor under this formula of 34%, the market shift adjustment is taking that back, so that the net associated with, again, this is on average, as I said, it fluctuates wildly from one hospital circumstance to another, is that it reduces that incentive for the hospital reducing volumes from $500 to $160,000. The amount that they would retain because of the application of the market share adjustment. Again, I don't have the data with me to present that. We can talk about that at a future meeting. But that's at least the basis of our analysis, which would indicate that there is a potential for this adjustment to actually undermine some incentives to reduce utilization. And that is kind of the root of Care First concern at this stage.
Bob, one of the things that we've asked, because we get the complaints on the other side, we've asked the hospitals on the other side to add in the amount of money they got for Medicaid adjustment and for population adjustment. And we would ask you to do the same thing with these declining hospitals, because some of them have an increase in their volumes that have been given back to them for Medicaid adjustment, as well as some of these hospitals have fairly, I'm looking at them, have fairly sizable population adjustments. And so they're actually retaining money for growth even when their volumes are dropping. So, let's add all the pieces together as we're thinking about it. That would be great.
So on the money follows the patient, the efficiency, and that came up with Mary Jo's comments. We are trying to do a service line specific calculation, so this way the shifts in orthopedic surgery are not compensating for the shifts in cardiac surgery. You could expect that the cardiac surgery in the hospital may be going down, but they are gaining orthopedic surgery from another hospital. We think that we need to do those calculations separately and provide resources for the hospital who is gaining orthopedic surgery, even if their cardiac surgery is going down. So, and then the zip code level calculations are also our attempt to make sure that the algorithm is trying to isolate the shifts between hospitals. In terms of aggregation, we got comments about whether the zip code level is appropriate level of calculation. So I wanted to provide an example of 2 zip codes in 2 hospitals. So these are somewhat real data. I reduced the number of hospitals. You will be surprised how many hospitals are serving in one particular zip code in Baltimore City. So one of the advantages of doing it at the zip code then is you are trying to make sure that the combinations are as detailed as possible. So in this case, we have the zip code 21224, and it's in both cases orthopedic surgery. So hospital A has ECMAT growth of 31 cases, and hospital B is losing 19. With the algorithm, hospital A is gaining 19 discharges. The second zip code, same orthopedic surgery, and these zip codes are geographically very close to each other. Hospital A has 2 ECMAT growth. Hospital B has 24 ECMAT growth. In this formula, since both of them experiencing volume growth, we have no market shifts in the second zip code. If you were to aggregate these 2 zip codes, what ends up happening is that we are masking the shift from the first zip code to hospital A. So when you combine them, you see the growth in hospital A is 33, in hospital B is 5. So both are showing increases, therefore we say no market shift. But in fact, when you segregate them, you see that there is a shift in one of the zip codes. On the other hand, we have some zip codes with very low population and also concentrated markets, meaning 1 or 2 hospitals are mainly serving these, mainly the TPR counties, where you have set of providers providing the services. And then on the service lines, we have some services where the volume is very scarce. So we think that it makes sense to combine the rural counties into a single unit. So we would combine all the zip codes from these counties into one total. So for Garrett, for example, all the zip codes in Garrett will be aggregated to Garrett County for all the hospitals. And then we would look at, again, the shifts at service line for the volumes from the counties. we considered adding, so this list is kind of open to input, but in general, we looked at the population density and the market concentration and tried to combine them so that we don't deal with small cell size issues for the counties. These are mostly rural, and except Frederick and Hartford and Carroll, those are the questions that we have, but the rest we think are kind of similar to the other counties in the definition. So EC mats, I had them in the table, just high-level calculations. So when you do the shift calculations, we can't just count the admissions, obviously. We have to make sure we adjust for the resource use for those shifts. So we do inpatient case mix adjusted counts for the inpatient side. And on the outpatient, it's more complicated because we don't have a DRG where you can combine all the services provided to a patient into a single definition. The rates are developed separately. We are trying to combine the radiation therapy, infusion, and drugs into a single category. Significant procedures is the next one, medical visits and others. So they are treated as their own unit when we look at their resource use. And the ECMAT is taking the inpatient case mix adjusted discharges, and then for the outpatient visits, converting them back to as if they are inpatient. So the ratio is 10%. So the charges of one visit in admissions in the inpatient case is 90% more than the outpatient. So then each outpatient visit counts only 1/10 of one admission on the inpatient. That becomes the equivalent case mix adjusted discharge. Once we develop the resource use adjustments, then we map those individual level definitions to the service lines. And as we mentioned, we take the PQIs and readmissions out from that. And for the outpatient, we use a hierarchy. So and here the rationale is trying to group the patients based on their reason for coming to outpatient. All ED visits are grouped into a single line service line, no matter what they do in ED. Then they have different weights within ED department. So if they have a procedure, and they significantly weigh higher than someone who came with abdominal pain and discharged 2 hours later. Then the other ones are drugs, major surgeries, minor surgeries, and the like. So I'm going to review some of the data, and maybe it will be more apparent once you get a sense of the data a little bit. So, and thank you, Kim, for making these readable, eligible. So on table 1, if you look at your packet, this is the 6-month data that we've been working on, and it's sorted by the marker shift column at the end with the red font. So you start with the discharges, but when you see the ECMADs, you see that the numbers are much lower. It's the function of adjusting for the case mix and taking the 1/10 of the outpatient visits in general. University of Maryland St. Joseph Hospital is at the top, and we've been, in January, we had tried to predict their marker shift using a similar formula, and we seem to be on track with our early analysis and what is coming up as the final data analysis. And at the bottom, you see Holy Cross Germantown. Since they don't have any base year data right now, it's showing as a marker shift, but we have specific ways of handling the Germantown data, and we'll incorporate that into the final tables. And since we are doing pluses and minuses, you see that the net impact is 0 statewide because it has to be coming from somewhere if you are avoiding a market shift in positive. On table 2, I wanted to kind of look at the distribution of the inpatient. And again, it depends on the hospital. In general, A lot of the shift is coming from the inpatient Table 2, EC-MAD growth, and market shift by service line. And here you see that the St. Joseph case, majority of them are coming from the inpatient cases, but there are some hospitals that they are getting from the outpatient. I want to make sure you're aware of the data issues that we are still dealing with. Outpatient data set is still not clean. We opened our data again for hospitals to resubmit. I expect that the outpatient counts will be significantly different for a few hospitals in the final analysis. And I'm going to move to Table 3. Just to get a sense of where the shifts are happening, I sorted this by the percent market shift. So the product category is dental for inpatient. We have very few cases, 216 statewide, and the market shift adjustment is 23. So 11% of the EC-MADs for dental service line is plus or minus awarded as market shift in the state. And as you look at it, once you exclude dental and drugs, as I said, drugs is impacted by the data problems we have currently. The rest of the service lines, the range is between 9% to 1% of the services that are impacted by the shift. Then the last two columns are looking at the number of hospitals with positive adjustment and negative adjustment. So this is on aggregate, meaning that the 19 hospitals in the state are receiving positive adjustment for dental service line, and 22 are losing from the dental service line.
So when you look further down on the list, you can see cardiovascular, orthopedic, 30,000 cases in one, 11,000 in another. You see relatively small market shifts. It's worth noting.
It's not a small number of cases, though. So if you look at the dollars that are associated with the market shifts, you're going to find more there than in dental, because dental didn't have any cases to start with. So it's still bigger dollars in that category.
But the movement is relatively small, the dollar movement, I think.
I think overall the movement in the whole market shift adjustment is relatively small. So I think the dollars moving overall is about 0.2%, isn't it?
Yes.
So it's a 0.2% movement.
And this captures 100% of the market shift on the inpatient side, but not necessarily 100% on the outpatient side because of movement to an unregulated space on the outpatient side?
So the movement on to the unregulated is not part of the analysis. The data issue we have is we are missing CPT codes in the outpatient from some hospitals. So it looks like their surgeries are going down. So they are losing market. It looks like they are losing market shift. It happened with Carroll Hospital. Once they put the CPT codes in, they leveled off. So you don't see that much of a shift in the outpatient side either. The movement to unregulated side, we have to look at other data sources. And under the contract, GBR hospitals are reporting if they shift the services, their own services to unregulated space. Yeah, it's pulled out of their GBR. So is
it possible, theoretically, if volumes are decreasing, but decreasing disproportionately, that there would be a market shift adjustment?
Yes. And you'll see a few examples where they have a general volume decrease, but they are gaining market shift. So we've been focused on the calculations in terms of the volume. Then the next question is, and Bob got into it a little bit, is the cost evaluations. Once we calculate how many admissions they have, how we would calculate the cost of these shifts and adjust the global budgets. In general, we would like to use the 50% variable cost factor. So the formula then is counting the EC mats and the market shift times the average cost times the 50% variable cost, and if we use the base year, then we would inflate it with the price update to get at the total adjustment for the global budget. In terms of average cost, we narrow it down to 3 options. One, we discussed this before, use just one number, statewide average, just to give you an idea of the range with the preliminary analysis. So it's around 13,000 average statewide. Option 2 is hospital overall cost per EC mat. So the range is from 19,000 to 10,000. So this is a hospital average cost. And the option 3 is going beyond the hospital-specific average to a service line-specific average. So if you take the 10,000, hospital with the 10,000 average, there is a variation in their cost based on their service line. Orthopedic surgery may cost 15,000. The dental might be costing 9,000. So, thank you. So option 3 is to use those very specific cost calculations at the service line at the hospital level. So this is hard. I'm hoping it will be. So on slide 14, I didn't want to share the hospital-specific tables because the counts are still fluctuating. But in general, I wanted to get an estimate of what the impact of these options are statewide. So the first row is the net impact. Even though the EC MAD calculations are revenue neutral, it comes to 0. The cost calculations differ because of the changes in the way we are calculating the cost. So if we use a statewide average, you see that the net impact to the state is 2.5 million net impact. Under this number, there is 30 million distributed to the hospitals with positives, and then 32 million or 33 million taken out from hospitals with market shift declines. So overall, the absolute total is 63 million. So 63 million is shifting between positives and the negatives. If we use the hospital average, then the numbers are slightly, very similar to the state average. At the statewide, there is not much difference, but you would imagine it will be significant difference at the hospital level. And number 3 is the service line specific average. Again, statewide, we have around 60 million total redistributed with a net impact of $524,000. So we've been discussing the revenue neutrality of the program. The way algorithm is working now is ensuring that we don't have too much of a variation that we need to be concerned about putting a limit on market shift adjustments, the way it's working. In terms of the timelines, we've been focusing on the 6-month data for the July update, and we would like to finalize the policy as soon as possible. Once we have the data, we will have the draft report to the Commission next week, and we're hoping with the 2 meetings we have left with the subgroup and with the payment work group in June, we should finalize the market shift calculations for July update. And there are issues already identified, like the definition of the potential avoidable utilization. There might be other things on the cost that we could take up for the next iteration for the upcoming year. And for the upcoming year, we're going to go into a 12-month period. So we will be looking at the 2015 calendar year data to 2014 calendar year data, and that will be for the next July of 2016. the end.
Thank you, and any of you who still have a voice can answer this question, please. On any of the pricing mechanisms, when you price this out, this is inclusive right now of any transfer, the impact of any transfer. So technically, once you do the transfer adjustment, would that be removed from this amount? So if, for example, even in option 3, where it's about a $500,000 impact, once you remove the transfer revenues, it's for the market shift, the remaining market shift, it will be less than that. Right. Okay. Second, because I know the Commission took action in February, I guess, on the St. Joe's piece, plus or minus any reconciliation you have to do there, don't we also have to remove that from the impact, because we've already provided that in 15, so the 16 impact would again be less than this amount for the market shift as well for that issue. Thank you.
There are two other issues that we need to resolve in the coming weeks. One is the Germantown, how the Germantown is interacting with the rest of the algorithm, and the other one is the system hospitals, especially those who are close to each other. If there are shifts happening between those, we need to make sure the algorithm is neutral in terms of the impact, that we do not shift pluses and minuses between the system hospitals who are reorganizing their services and shifting patients.
And so for the Germantown hospital, for example, we would probably be adding money back, because we're taking money out for St. Joe's, but we took money out of Holy Cross already. So basically, if we implemented this and said this was accounting for everything, then we would have to add that money back that we withheld from Holy Cross's rate.
Mike Kern had a question about details on complex patients. Can you speak? Mike, could you reiterate your question? He has a microphone or the telephone?
He's unmuted? Not muted.
Not muted. Mike, you are self-muted. You can unmute. I'm not sure how, but... It came with the transfer. I'm guessing the transfer had the complex patients in. So just to remind you, the transfer policy is really focusing on the transfers to academic medical centers. And as Ray pointed out, we're looking at significant differences from their base year. So it's not a fine-tuned adjustment. If they increase their transfers by 10 additional cases, then the transfer adjustment kicks in for descending hospitals.
Can you hear me now?
Yes, we can, Michael.
Thank you. I think you were addressing it. Ray mentioned I had previously sent my comments. I just think it's important to understand what falls into those complex cases. Appreciate the role of the academic medical centers, but want to make sure that basic cases are not being transferred into those centers if not necessary.
Right, and actually, if under these calculations, if hospitals stop transferring basic cases to the academic medical center and treated them, then money would move back to the hospital at the time of the market shift adjustment. So that's how that would actually change the flow of money.
Thank you.
The shift to academic medical centers for increased transfers happens concurrently as the shifts happen during the year. But the market shift adjustment back to a hospital that would decide to provide the service locally and treat the patients would happen once a year during the market shift adjustment.
Thank you.
Mm-hmm. All right, there seem to be no other comments, and thank you for your patience with my voice. So comments from the public? Anything online? Sure, you will need to come and identify yourself and speak to the microphone. We all know who you are.
Hi, Beth Greskovich with Berkeley. My question is, I just want to confirm with the PAU that observation greater than 24 is being considered as readmissions or PQIs, so that.
That's right.
Okay.
That's right. So we are treating cases 24 hours or more, just like inpatient cases. So they are part of the readmission algorithm. PQIs are attached to them. So it will differ from the readmission reduction program, which is only inpatient. All right.
I think we can adjourn then if there's no other questions. We're done. Thanks, everybody.